Post-operatively, corneal edema and striate keratopathy was significant in few cases, but usually it resolves within a couple of days. And these were the observations and the results. So there's no significant differences in BCVA in post-operative patients of both the group. However, phacoemulsification leads to a lower rate of astigmatism, but there was no difference in the post-operative complications, and cornea was quite okay. So to conclude, soft nuclei can be easily manipulated through the 3 mm incision, and corneal complications are similar, and this is very shorter learning curve and no higher resources and no machine dependencies there. So PG students can be taught implanting foldable IOLs in these cases. Thank you so much for your kind attention.
Thank you, Dr. Vaishali. So now we move to Dr. Twinkle. He will be speaking on combating CO morbidities, cataract and glaucoma together.
Good morning, everybody. Thanks, Chair, Dr. Mathur, Dr. Puramani, and Dr. Nayak. I acknowledge Dr. Puri Bhagat for supporting me for this talk. Cataract and glaucoma, both effects on the elderly. Coexistence is either primary or a secondary. Just Dr. Deepak has already shown the one of the phacomorphic glaucoma, the phacomorphic, phacolytic, or sometimes the ectopia lentis, or sometimes the steroid-induced glaucoma. So many glaucomas are there which are combining with the cataracts. So now we go one by one, how the impact of cataract on the glaucoma evolution. Intumescent cataract, it produces the issue shallowing, it is more mimic like a PAC, primary angle closure disease. The same way, it prevents the proper opening of head visualization. Also, the visual field, which is versus the mean deviation across all the tests, all chances of artifacts, it's very difficult to find out about the progression of this, and interpretation has to be very cautiously. The same way, imaging quality, the false underestimation of the retinal fiber layer because of the denser cataracts. The other way around, the impact of glaucoma on the cataract. Cataractogenesis is faster with the higher elevation of the IOP for the longer time. Some medicines like a pilocarpine, which is hastening the cataractogenesis, which is also contraindicated posterior subcapsular cataracts. Trabeculectomy, progression of the cataract, especially in the postoperative shallow AC, plus or minus inflammations, impact on the visual prognosis, and necessitates the modification in the cataract surgery technique. Now, how to evaluate these patients who have a coexisting glaucoma and the cataract? Most important part is the conjunctiva, selection of the site before going for the surgery, because we are going to have a lab on that particular area. Antechamber depth, shallowing in the antechamber, you have to go for the hair viscoelastics, retentive viscoelastic. Ciliary lenticular block is very common in these cases. And careful IOL power selections, you cannot go for the regular formulas like SRKT or Barrett one. You should go for the offer Q or offer QST one. Adequate BTS, especially in the patients on the myotics, posterior synechia, and pseudoexpulsion. When you find any pseudoexpulsion, it's very important to go for the dilatation, which is very mandatory, because those patients have always a poor corneal endothelium. They have a zonal instability, and you have to go for a little bit larger axis. There are postoperative capsular contractions. So in those patients who find any pseudoexpulsions, go see whether the pupils are dilating properly, and if zonal status are good, it's preferably to go for the early cataract surgery in those patients. Adequate glaucoma control before the surgery is very important. And preoperative counseling for the patients and the long-term follow-up is very necessary. That counseling has to be done. Now, proper evaluation of the glaucoma in those cases are very important. So gonioscopy is must. Large area of synechia, cataract surgery alone would not be helped significantly. Compression gonioscopy has to be done if the lens contributes to the narrow angle. If you find that you are planning for the angle surgeries, particularly eye stent type of surgeries, you have to carefully look for the angles. Pelvis may appear pink due to the nuclear sclerosis. You have to keep this in mind. Intersegment imaging, particularly angle, lens thickness, and vault if with the ASOCT, visual field analyzers. Important to counsel regarding the prognosis, because that will give you a very good idea about how much the damage of the glaucoma is already there. And suppose very dense cataract, you should document by the USG about the optic nerve aid. General principle before the surgery, stop the PG analog and miotics 1 to 4 weeks prior. May substitute with a systemic drug. Perioperative IOL as low as possible, it is very important. Avoid the large volume of the local anesthesia and the local massage. Avoid adrenalines. And if the patient is cooperative, in very advanced cases, it is better to go for the topical anesthesia. What should one do? So many options for the surgery when you have a combining cataract and glaucoma. Either SICS only and treat the glaucoma with the medication. Simultaneous SITS with the trap. And trap followed by the SICS. Laser trabeculoplasty followed by the SICS. Or newer anti-glaucoma surgeries plus SICS. We first go for first three in the scope of the drug. SICS only. When there is a well-controlled IOP with the tolerating 1 or 2 drugs on the anti-glaucoma medications, minimal optic nerve damage is there, or ocular hypertension cases, or lens-induced glaucoma like phacomorphic glaucoma or spirophakia, as Dr. Migur has already shown nicely about the surgery. Simultaneous SICS and TRAB, when we will go for that. Moderate or advanced glaucoma and poor control in spite of the multiple medications with significant cataract. Compliance or tolerance or affordability is an issue with the medication, or when separate or stage surgeries cannot be performed because of the high risk anesthesia or multiple health issues, or patients' visits are very difficult to have for the follow-up. So either you can go for the one-side surgery, you go for the scleral tunnel. If you have phaco with the IOL for the one-side surgery, it's more preferable rather than a SICS, even though if you are going for the SICS. Then either by the Kelly sponge, you can go for the trap, or you can open up the your tunnel and you can do a trap and suture the conjunctiva. Two-side surgery, superiorly you can go for the tunnel formation, and the temporally you can go for the SICS surgery. And then you can do a trap from the superiorly again and suture the conjunctiva. Trap followed by, just 2 slides please. Trap followed by the SICS, particularly when visually insignificant cataract need a very low IOP target. Advanced glaucoma unlikely to tolerate the postoperative IO spikes. Very high IOP, not controlled medically or causing the corneal edema, precluding safe visualization of cataract surgery, and high-risk cases where the poor prognosis like uveitic or neovascular glaucoma or scarred corneal ocular surface. So to conclude, you have to individualize the surgery, surgeon's comfort, patient's expectations, ocular systemic and socio-economic status, meticulous planning for these cases. Cataract surgery does not cure vision loss due to the glaucoma. Combined surgery less efficacious than the trap alone, and lifelong follow-up is very essential. Thanks for attention.